Somewhere in the world, a stroke happens roughly every 40 seconds. In the time it takes you to watch the next few minutes of this video, several hundred more will happen. Worldwide, strokes take close to 6.5 million lives every single year, making it the second most common cause of death on the planet, and the single biggest reason adults end up needing permanent daily help just to get through life. Here's the part almost nobody explains clearly. In a large share of cases, the brain sends out a very specific, very readable distress signal hours, sometimes days, before the major event actually hits. Most people just don't know what that signal looks like, so they miss it completely. I'm Joshua Smith, and if plain language health information without the fear-mongering or the jargon is useful to you, stick around, subscribe, and hit that like button so more people can find videos like this one. Here's the first thing worth unlearning. A stroke is almost never a bolt out of the blue. In the overwhelming majority of cases, a blood vessel has been quietly wearing down for years, sometimes decades. And the moment someone ends up in an emergency room is simply the last domino falling in a chain that started long before. And when something develops slowly and predictably, that also means it can often be caught and interrupted before that last domino falls. That's really the whole point of this video. When people say the word stroke, they're actually lumping together two quite different medical emergencies. The first is a hemorrhagic stroke, where a blood vessel inside the skull actually ruptures. Blood escapes into the surrounding brain tissue, pressure builds quickly, and a large share of these cases are fatal. The second, far more common type, is an ischemic stroke, where the vessel doesn't burst at all, it simply gets plugged, usually by a clot. Blood flow to a section of brain tissue stops, and starved of oxygen, the cells in that area begin dying within minutes. Roughly 8 or 9 out of every 10 strokes fall into this second category, so that's where we'll spend most of today's video. To understand why minutes matter so much, it helps to know just how energy hungry your brain actually is. It weighs somewhere around 3 pounds, roughly 2% of your total body weight, yet it burns through about a fifth of every breath of oxygen you take and close to a quarter of the sugar circulating in your blood at any given moment. It's an organ that never clocks out, and it keeps almost no fuel in reserve. Cut off that supply line for even a handful of minutes, and brain cells start dying in ways that generally can't be undone. That's the entire reason stroke treatment gets described as a race against the clock. It isn't a figure of speech. It's a race to rescue tissue before it's gone for good. Here's the part most people never hear. For an artery in the brain to suddenly seal shut, the groundwork usually takes years. The inner wall of that vessel gets damaged bit by bit, fatty deposits and small clots build up along the lining, and the channel blood has to squeeze through keeps getting narrower. None of this happens overnight. It's the final step of a long, slow process, and along the way, your body typically fires off warning shots. The trouble is that almost nobody is ever taught how to recognize them. In medical terms, those warning shots have a name: a transient ischemic attack, or TIA. Transient simply means it doesn't stay. Picture the main artery running up either side of your neck, feeding blood to your brain. Over years, a fatty deposit forms along the inner wall, usually right where the artery splits into smaller branches, and the passage narrows bit by bit. At some point, that already tight vessel briefly spasms, or a small fragment breaks loose, blood flow to part of the brain drops for a short window, somewhere between 30 seconds and about 10 minutes, and a stroke symptom shows up. Then the vessel relaxes, blood flow returns, the symptom disappears, and most people exhale and go back to their day, telling themselves it was nothing. What the research actually shows is that a TIA is frequently a direct preview of a much larger stroke, and the danger is front-loaded. Risk is highest in roughly the first 2 to 3 days afterward, though doctors keep watching closely for a few months beyond that. Those first few days are exactly when a full-blown stroke can often still be headed off, and most people never use that window, simply because the episode was brief and strange and then it vanished, so they talk themselves out of taking it seriously. Let's walk through 5 specific warning signs, and for each one, I want you to understand not just what it looks like, but what's actually happening inside your body when it happens. The first is sudden temporary vision loss in a single eye. You're going about your morning, and out of nowhere, the vision in one eye dims, blurs, or goes almost completely dark, like a shade being pulled down over just that eye. Within a minute or two, sometimes less, your sight comes back to normal, and you chalk it up to standing up too fast or plain eye strain. What's actually happening in a lot of these cases is that a tiny clot or a small piece of plaque broke free from the wall of your carotid artery, traveled upward, and briefly lodged in the small artery that supplies your retina. That eye artery isn't some separate, unrelated blood vessel, it's a direct offshoot of the same carotid artery that feeds your brain. When that fragment wedges into place, the retina, the light-sensitive tissue lining the back of your eye, is temporarily cut off from blood, which is why you get that curtain-like darkness instead of clear vision. Once the fragment dissolves or drifts onward and blood flow resumes, your sight returns and it feels like nothing happened. It wasn't luck though, at least not the good kind, because that exact same fragment could just as easily have traveled a couple of millimeters further into an artery feeding brain tissue instead of your eye, and then you'd be looking at permanent vision loss, paralysis, loss of speech, or worse. There's a formal medical term for that one-eye blackout, amaurosis fugax, Latin for fleeting blindness, and doctors treat it with real urgency because the odds of a full stroke following within hours are genuinely elevated. There's a well-documented pattern of people brushing off 2 or 3 of these eye episodes, only for the next one to be the big one, this time in the brain instead of the eye. The second warning sign is sudden numbness, or a pins and needles feeling confined to one side of the body. It might be a whole arm, just a hand, one side of the face, or one entire side of the body at once, and people often describe the limb as suddenly feeling rubbery or completely dead. The defining feature is that it appears out of nowhere while you're sitting, standing, or mid-conversation, lasts a few minutes, and then fades on its own. Now, you've probably had the experience of waking up with a dead arm because you slept on it. That's genuinely different, and here's why. That kind of numbness comes from a nerve being physically pinched, and it clears up within a minute or two of shifting position and getting blood moving again. With a TIA, the issue was never in your arm at all. It's in the specific patch of brain tissue responsible for sensing that arm, and repositioning your body has nothing to do with why it eventually resolves. One more pattern worth knowing. Stroke-related symptoms are almost always one-sided because each half of your brain governs sensation and movement on the opposite side of the body. If both hands go numb evenly at the same time, that tends to point toward a neck or spine issue rather than the brain. But sudden numbness confined to one side that resolves within minutes is enough on its own to justify getting checked for a TIA. The third warning sign is a sudden loss of coordination, your gait suddenly going wrong, as if your body briefly forgot how to walk in a straight line. You're on flat, familiar ground, and suddenly a foot lands wrong, a leg buckles or feels rubbery, or you stumble into a wall or a piece of furniture for no clear reason. Some people instead get hit with an intense spinning sensation out of nowhere, grabbing a countertop or door frame even though they never turned their head quickly or stood up too fast. The structure responsible for balance and smooth, coordinated movement is your cerebellum, tucked low at the back of your skull, almost like a second, smaller brain. It constantly tracks where your limbs are in space and fine-tunes how much force each muscle should use, so you walk in a straight line instead of drifting. The cerebellum gets its blood supply through a set of arteries that travel up through the bones in the back of your neck, and if flow through that system drops even briefly, the cerebellum effectively glitches, and that's the moment you veer sideways, misstep, or feel that sudden, unprovoked spinning. In clinical settings, there's a well-known pattern of people blaming these moments on worn-out shoes, exhaustion, or a blood pressure reading, only to learn later they'd actually experienced a cerebellar TIA. Ordinary dizziness usually has an obvious trigger, like rolling over in bed or a known inner ear issue. Sudden, unprovoked dizziness paired with trouble walking straight deserves a medical evaluation rather than an explanation you invent for yourself. The fourth warning sign shows up in speech, and it's worth drawing a clear line first. Forgetting your neighbor's name for a second, or blanking on an ordinary word, especially when you're tired, is completely normal and not a stroke sign. What actually concerns doctors is something far more dramatic. Your speech suddenly breaking down badly enough that you yourself sense something is seriously wrong. Most people have 2 key language centers, typically on the left side of the brain. One helps you physically form words and send the right instructions to your tongue, lips, and jaw. When blood flow to that area drops, you might know exactly what you want to say, but the words come out slurred, garbled, or won't come out at all. The other language center helps you understand what's being said to you and organize your own sentences so they make sense. When that area is affected, a person might speak fluently but string together words that don't actually add up to anything, and may struggle to follow simple requests. If a speech problem like this appears suddenly and clears up within minutes, that's a textbook TIA, not ordinary tiredness. And a symptom disappearing on its own doesn't mean nothing happened. It usually just means your brain found a brief detour around the blockage. The blockage itself hasn't gone anywhere. The fifth warning sign tends to surprise people the most, and I want to be upfront that the science behind it is still developing. So treat this one as a reason to ask more questions rather than a hard rule. It involves a combination of certain autoimmune conditions, things like vitiligo, where patches of skin lose their pigment, alongside a new pattern of unusually intense headaches that don't match anything you've experienced before. Conditions like vitiligo happen because the immune system mistakenly attacks the body's own cells. And some research suggests that when the immune system is already misfiring in one place, it can occasionally inflame the inner lining of blood vessels elsewhere in the body too, a layer called the endothelium, the smooth inner surface every artery relies on to keep blood flowing cleanly. When that lining becomes inflamed, it can turn rough, and rough surfaces are where cholesterol, platelets, and clotting material tend to accumulate over time. To be clear, having vitiligo or another autoimmune condition does not mean a stroke is coming. But if you have a diagnosed autoimmune condition and you're also noticing a new, unusual headache pattern, that combination is worth mentioning to a doctor as part of a broader vascular check-in, rather than something to quietly sit with on your own. On headaches generally, they're genuinely tricky to interpret, because plenty of head pain has nothing to do with blood vessels at all. A very common source of frequent headaches is simple wear and tear in the joints of the upper neck, essentially arthritis, which can irritate nearby nerves and refer pain up into the head. An undiagnosed disc issue in the neck can do something similar. The takeaway isn't to panic over every headache, it's to stop treating a changing or unusual headache pattern as something you just medicate through, especially alongside any of the other 4 signs we just covered. Now let's talk about what actually wears down your blood vessels from the inside. Because there's a myth here that trips a lot of people up. The idea that if your cholesterol numbers look fine on paper, you're not at risk. Stroke risk isn't only about what's floating around in your bloodstream, it has just as much to do with the condition of that inner vessel lining we just talked about, the endothelium. Picture a length of smooth, polished pipe. While the interior stays smooth, blood moves through cleanly with nothing catching on the sides. Once that interior gets scratched, pitted, or scarred, everything starts snagging instead of gliding past. Chronically elevated blood sugar is one of the biggest culprits behind that kind of damage. Glucose is fuel for your cells, but to actually get inside an endothelial cell, it needs insulin to unlock the door. When your body isn't producing enough insulin or your cells have become resistant to it, you can have plenty of sugar floating in your bloodstream while the cells lining your vessels are still functionally starving. Starved cells become damaged, lose their normal shape, and in some cases detach from the vessel wall entirely, leaving behind a rough, scarred patch. Those damaged sections lose the flexibility to properly widen and narrow as your blood pressure shifts, something doctors call a loss of vasomotor reserve, and they become prime real estate for LDL cholesterol, platelets, and other debris to pile into the plaques that eventually choke off an artery. This damage typically begins years before anyone is officially told they have diabetes. Even mild prediabetes, where blood sugar sits just slightly above normal, is enough to quietly injure that lining over time. The second major threat to your blood vessels is smoking. Tobacco smoke carries thousands of chemical compounds, a long list of which are established carcinogens. But where stroke is concerned, the relevant damage is to the endothelium and to the blood itself. Every cigarette sends a fresh wave of toxic compounds across that inner vessel lining, triggering direct chemical injury and inflammation. At the same time, nicotine and carbon monoxide make your blood noticeably thicker and stickier, so platelets clump more readily and clots form more easily. Combine an inflamed, roughened vessel wall with thick, clot-prone blood, and you've built close to ideal conditions for a blockage, which is a large part of why smokers face somewhere around 2 to 4 times the ischemic stroke risk of non-smokers with otherwise similar cholesterol and blood pressure numbers. Blood pressure introduces a genuine paradox, and it runs in the opposite direction from what most people assume. Nearly everyone has heard that high blood pressure causes strokes, so people tend to relax the moment a reading comes back low or normal. Chronic high blood pressure absolutely is one of the strongest risk factors out there, because over years it physically stresses vessel walls and speeds up plaque buildup, and it's the leading driver behind the hemorrhagic or bleeding type of stroke. Here's the twist. An ischemic stroke frequently strikes not at the peak of someone's blood pressure, but at a relative low point. Picture an artery already narrowed by more than half from plaque buildup, like a garden hose with a kink pressed into the middle of it. As long as pressure in the system stays high enough, some water still forces its way through that kinked section. But if overall pressure drops, flow through that already tight point can fall close to zero, especially if a small clot happens to be sitting right there, and there isn't enough force left to push it along. Every night while you sleep, blood pressure naturally dips somewhere around 15 to 20%, which is completely normal on its own. But if you already have a narrowed, plaque-laden artery, that ordinary nighttime dip can be exactly enough to turn a partial blockage into a complete one, particularly if a clot has been quietly forming on that plaque while you were lying still. That's part of why some people go to bed feeling completely fine and either wake up with stroke symptoms or are found that way by someone else in the morning. Age matters too, though not in the oversimplified way it usually gets discussed at family gatherings. Stroke risk climbs meaningfully after around age 50 and roughly doubles with each following decade. In older adults, the dominant causes tend to be plaque buildup, long-term high blood pressure, and heart rhythm irregularities. But somewhere between 10 and 15% of strokes happen in people under 45. And in that younger group, the underlying causes look different: inherited vessel abnormalities, weak bulging spots in a vessel wall called aneurysms, clotting disorders, autoimmune conditions, and head or neck trauma. There's also a speed factor worth knowing. Past roughly age 40, the same risk factors, smoking, high blood sugar, high blood pressure, tend to damage vessels at close to double the rate they did in your 30s, which is part of why doctors get noticeably more assertive about these numbers once patients move into their 40s and 50s. So what do you actually do if you've experienced even one of these 5 warning signs, even if it felt minor and disappeared in under 10 minutes? You're typically looking at a window of roughly the first 2 to 3 days where meaningful prevention is still very much possible. The goal isn't to panic, it's to not waste that window. Stroke specialists consistently emphasize not being completely alone in the period right after a suspected TIA, which is genuinely worth planning for ahead of time with your family and your doctor, particularly if you live by yourself. If a more serious episode follows and you suddenly can't speak or move, you need someone nearby who can notice, call for emergency help, and reach you quickly. It's worth simply telling someone close to you what happened and making sure they can reach you easily over the following couple of days. Stroke guidelines also generally advise against driving yourself anywhere after a possible TIA. Losing vision or control of an arm for even a few seconds at highway speed puts you and everyone around you at serious risk, so it's worth having a transportation plan sorted out ahead of time with your doctor rather than being tempted to drive yourself in if something like this happens. Checking blood pressure is typically one of the first steps in any acute situation. If you or someone with you can measure it and the top number sits around 180 or higher, or the bottom number sits around 110 or higher, that fits the picture of a hypertensive crisis rather than simple elevated blood pressure. And that in itself is a serious enough warning sign that calling emergency services is generally the recommended move. Ask your own doctor ahead of time exactly what threshold they want you to treat as an emergency, since guidance can vary based on your history. One rule in stroke medicine is treat it as close to absolute. Never start a blood thinner like aspirin or any anticoagulant on your own, based on something you read online or advice from a friend. Strokes come in 2 very different forms: blocked vessels and bleeding vessels, and thinning the blood can help in some situations involving a blocked vessel, while making a bleeding stroke considerably worse, potentially fatally so. The only reliable way to tell which type is happening is brain imaging, typically a CT scan, in a hospital setting, and no amount of guessing at home changes that. While you're waiting for help or being transported, body position matters more than people expect. Lying down is generally better than sitting upright, since it supports blood flow to the brain, and many clinicians suggest a flat, comfortable position with the legs raised slightly above chest level to ease circulation and reduce strain on the heart, with the head kept neutral rather than sharply tilted forward or thrown back, so the neck vessels aren't compressed. It's also sensible to avoid smoking, alcohol, and hot showers or baths in that moment, since suddenly widening blood vessels in an already unstable system can make things worse. As always, confirm specifics with your own doctor ahead of time. Keeping an up-to-date written list of every medication you take somewhere easy to find is a small step that can genuinely save emergency responders valuable time. Here's something a lot of people get backwards. If a few days pass without a repeat episode, that doesn't mean you've dodged the bullet entirely. It means you were handed a second chance, and that chance still needs to be used. There are 3 specific evaluations worth asking your doctor about at your next visit if you've experienced any of these warning signs, and each one examines a different piece of the puzzle. The first is a specialized scan called a carotid duplex ultrasound. Unlike a basic ultrasound that only shows structure, duplex imaging shows both the shape of the artery and how blood is actually moving through it, including whether flow speeds up and turns turbulent at a narrowed section. If a carotid artery turns out to be narrowed by more than roughly 70%, doctors describe that as a hemodynamically significant blockage, severe enough to meaningfully choke off blood flow. At that stage, the real question shifts from whether a stroke might happen to when it's likely to happen if nothing changes, which is why a surgeon may recommend a procedure called a carotid endarterectomy, where the plaque is physically removed from inside the artery. It sounds dramatic, but in modern practice, it's a routine operation performed regularly, and it prevents a great many strokes every year. If you have relevant risk factors or symptoms, this is a completely reasonable thing to raise with your doctor. The second test is a blood test called hemoglobin A1C. This measures the percentage of your hemoglobin, the oxygen-carrying protein in red blood cells, that has sugar molecules stuck to it. The higher your blood sugar has run over the past few months, the higher that percentage climbs, which is why this test reflects your average blood sugar over roughly a 3-month stretch rather than a single morning reading the way a fasting glucose test does. You can't fake a good result with one clean fasting number the day before the blood draw. It's particularly good at catching that gray zone known as prediabetes, where sugar levels have been elevated long enough to start damaging vessels without ever being labeled full diabetes. The reference ranges are well established. Under 5.7% is considered normal, 5.7 to 6.4% falls into prediabetes, and 6.5% or above typically indicates diabetes. If it's been years since your last one, or you've never had one at all, that's an easy, low-effort thing to bring up at your next appointment, especially with any stroke risk factors in the picture. The third evaluation is Holter monitoring, essentially a continuous heart rhythm recording worn for a full day or two, rather than the brief 10 or 20-second reading you get during a typical office visit. The reasoning is straightforward. Certain dangerous heart rhythm problems come and go, sometimes appearing for only seconds at a time, and a short snapshot reading in the clinic can miss them entirely. The biggest rhythm-related culprit for stroke is atrial fibrillation. In atrial fibrillation, the heart's upper chambers stop contracting in a coordinated way and instead quiver chaotically, sometimes several hundred times a minute. Blood doesn't empty cleanly from those chambers when that happens. It swirls and pools instead, and pooling blood clots easily. Those clots can travel from the heart up to the brain and lodge in an artery, producing what's called a cardioembolic stroke, which tends to be especially severe. Plenty of people with atrial fibrillation don't notice dramatic symptoms. Maybe an occasional skipped beat or flutter they blame on stress or coffee, which is exactly why extended monitoring is what catches it. When atrial fibrillation is identified, well-studied blood-thinning medications, properly prescribed and monitored, can cut the associated stroke risk by somewhere in the neighborhood of 60 to 70%. That's not a fixed outcome. That's a risk you and a cardiologist can actively manage together. Stepping back, a stroke is rarely a lightning strike out of a clear sky. It's typically a predictable outcome following years of quiet vessel damage, and more often than people realize, it announces itself in advance. You now know the 5 signs to watch for: brief blindness in one eye, sudden numbness or tingling on one side of the body, a sudden loss of coordination or balance, a sudden breakdown in speech, and treated with appropriate caution, a combination of an autoimmune condition like vitiligo alongside a new unusual headache pattern. Any one of these showing up for the first time, even if it resolves in under a minute, is worth an urgent conversation with a doctor and a direct question about those 3 evaluations: carotid duplex ultrasound, hemoglobin A1C, and Holter monitoring. On the prevention side, keeping blood sugar in a healthy range and catching prediabetes early protects that vessel lining and slows plaque growth. Managing blood pressure with your doctor, avoiding both dangerously high and dangerously low extremes, reduces strain on your vessels, and lowers both major categories of stroke risk. Quitting smoking, with support if you need it, removes a constant chemical assault on your arteries and can cut ischemic stroke risk by roughly half to 3/4 over time. And the single most important idea to walk away with: don't wait for a brief, strange symptom to simply pass on its own and assume that means it wasn't serious. In stroke medicine, you typically have somewhere around the first 72 hours where real prevention is still on the table. If anything in this video sounded familiar, even something that happened months ago, write it down in plain language and bring that note to a doctor rather than relying on memory. Ask directly whether you should be evaluated for a transient ischemic attack, and whether a carotid ultrasound, an A1C test, or Holter monitoring makes sense for you. If you're already managing risk factors like elevated blood sugar, high blood pressure, smoking, or an autoimmune condition, use what you learned here to have a more specific, numbers-based conversation with your doctor rather than settling for a vague "everything looks fine." Everything covered in this video is meant to inform that conversation, not replace it. Your own situation is specific to you, and a real conversation with your own doctor will always serve you better than trying to manage any of this alone. If this helped make a complicated topic a little clearer, consider subscribing and leaving a like. It genuinely helps this channel reach more people who need it. Thanks for watching, and I'll see you in the next one.